Hello everybody and welcome to Hughes Clues Traumatic Brain Injury. You might also see this listed as closed head injury or just head injury, but the proper name is traumatic brain injury. And this slide may look familiar to you. This is what we did in the first part of the semester, or at some point we've done this piece before. And here's what we have to consider for taking care of any patient with any type of intracranial issue, is that everything, the brain, the CSF, and the blood, are enclosed within this hard box, which is the skull. And these substances are meant to be, these three things, brain, CSF, and blood, they are meant to be in the proper ratio. So you can see that the brain occupies the majority of the space inside the head, and then the blood and the CSF have, it seems to be, equal parts. And because this cranium is very hard, and these substances are contained within it, then that creates pressure inside the head, and that's known as intracranial pressure, ICP. And if for any reason one of these things, one of these items, either the brain, the blood, or the CSF, begins to take up more space than they're supposed to, then that is going to cause an increase in the intracranial pressure inside the head, and this frown would, or this smile would turn upside down. Again, just to test your memory, tell me what would happen. Give me a specific number if there was some brain swelling. What would you expect the ICP to do? And of course you know that that ICP would be elevated and it would be greater than 5 to 15 because 5 to 15 is normal. So if the ICP is elevated, then it would be a number that's higher than normal. Again, this is back to the patho, and I'm not going to belabor this because I know that you've had this before. But you guys know that your brain has to have oxygen. It cannot be without oxygen or glucose. It cannot do anaerobic metabolism, and it has to have glucose. It doesn't need insulin to get glucose. Otherwise, you have an issues. And if any of these things, especially oxygen, is lacking, then your brain, once your brain cell is without oxygen, then through this little process here, the brain cell is going to swell. And there are lots of other reasons that can cause brain cell swelling. And of course, that would be trauma or infection or any kind of inflammatory disorders. And once these brain cells start to swell, then that can impinge or decrease the perfusion to the cell nearby. Then that would cause it to swell, and then that would cause the next cell to have diminished perfusion, and so on and so on and so on. The bottom line is that brain swell causes more brain swelling, and the ICP keeps going up. And in any kind of traumatic injury or any kind of problem that causes cerebral edema, that is usually what the individual will die from this increased intracranial pressure and problems in the brain, and not necessarily the original injury that occurred. And as you know, if you listen to the news and you've heard about Bobby Christina Brown, that she drowned in the bathtub, it doesn't take very long for individuals to lack oxygen and then to have brain death. It's usually 4 to 6 minutes. Here's our mechanisms for brain injury, and because we're going to be doing traumatic brain injury, we're going to focus on the trauma part of it. And of course the brain has compensatory mechanisms. That way, if you stand on your head, it can still have adequate blood flow, and there's the information there. You've got to have a mean arterial pressure. The best is 70 to 150 to ensure that your CPP, your cerebral perfusion pressure, is adequate. And how do you know if the cerebral perfusion pressure is adequate? Well, it takes a number, and that number is anywhere between 60 to 100 millimeters of mercury. With a CPP of less than 50 is decreased brain perfusion, but in my thinking, anything if 60 to 100 is normal, then anything less than 60 is not a good thing. And how you calculate the CPP, the cerebral perfusion pressure, is you take the MAP minus the ICP. So again, we have to go back to our basics. We have to know how to calculate a MAP, and then once we have an ICP value, then we can get a CPP value. And I've given you 3 different blood pressure values, and then you needed to calculate the CPP just for fun. And I just want to make sure that you remember how to do this. And if you're having any issues at all, then just be sure and let me know. And just remember that if you see an ICP and a blood pressure on that test, you really, really, really need to calculate the CPP. That's what she's pretty much heading towards. Let's get to the traumatic brain injury scenario. We've got a 22-year-old construction worker, and it just kind of dawned on me, I really always use construction workers, that arrived in the emergency department after multiple blows to the head from a hammer. He experienced a brief altered level of consciousness at the accident scene, but is now awake and oriented and complaining of a bad headache. He denies any previous medical problems, and a deep head laceration is noted where the hammer connected with his scalp. Your assessment data, the nurse's assessment data, notes that the airway and breathing are going to fall within normal limits. The C-spine is also cleared by the physician. And then vital signs are as follows. The GCS, Glasgow Coma Scale, is 15, and the pupils are equal and reactive at 4 millimeters. So what should concern you regarding his initial complaint? Well, any patient that suffers a blow to the head or the scalp, you have to consider that there could be a potential for a brain injury. You're not sure if you, regardless of what it looks like, you don't know how deep that scalp laceration is. So you've got to kind of think, well, maybe there's damage to the skull, and of course there could be damage to the brain underneath. You always have to think, anytime there's some kind of brain issue, that you have the potential risk for increasing ICP and altered, especially diminished cerebral perfusion pressure. As the nurse continues to care for this patient, they note that there's periorbital edema. That's just a fancy way of saying that there's edema around both eyes, and there's also bruising. And there's also post-auricular ecchymosis. That's bruising and behind the ear. And this sign right here, this bruising and ecchymosis to both eyes, is known as raccoon's eyes because, of course, it kind of looks like a raccoon. And then the damage or the ecchymosis behind the ear, the bruise behind the ear, is known as battle signs. And then a clear nasal drainage is also noted. Well, what's the clinical significance of these findings? Well, these clinical manifestations are often found with a linear skull fracture. And the battle's eyes and the battle sign and the raccoon's eyes is fairly common with the linear skull fracture. But of course, if you see stuff dripping from someone's nose, you might think, well, maybe that's just snot. They could have had a cold before somebody bashed them in the head with a hammer. So you're going to look at that drainage, and you're going to drop it on a piece of paper or some kind of white object, white paper. And then if it's CSF, because that's what you suspect whenever there's a linear skull fracture, that it could be a CSF that's leaking out, then the fluid will separate into a halo with blood in the center and then the CSF fluid on the outside. And if you took a dextrose stick, that's something that you use to test urine for different chemicals and stuff, you can use that same dextrose stick to stick into this fluid, into this drainage, and it will test positive for glucose. Thankfully, snot does not contain glucose, or we'd never get our kids to stop picking their nose and eating it. The patient suddenly begins to vomit. You turn his head to the side, ensuring that he does not aspirate, and you notice that he is now less responsive. What are your priority interventions, and what might these clinical manifestations, signs and symptoms, indicate? Well, priority interventions are always going to be the same. It's A, B, C. So as we look at this individual and we notice that he's not as responsive as he is, and if we assessed and his breathing was really less than a normal amount, then we would consider that this individual needs to be intubated and his airway needs to
be protected. Any kind of traumatic brain injury can depress the respiratory center in the brain, and you will cause hypercapnic respiratory failure. In other words, the respiratory rate will go down, the individual will retain CO2, and that's known as hypercapnic respiratory failure. If you're thinking that the pH would become acidic, then you would be correct, and you could have respiratory acidosis. Part of our next assessment or priority intervention is going to be C, circulation. So we're going to ensure that we have at least one, if not two IV lines, and we're going to reassess his blood pressure and heart rate. And here we have a blood pressure of 140/70 and the heart rate's 58. His level of arousability is decreased, as we've already mentioned. He only makes unidentifiable sounds, and he opens his eyes and withdraws to painful stimuli. Again, close your eyes, imagine that Glasgow coma scale in front of you, and tell me what you think it might be. Pupils are now slow to react to light, and they are unequal. Because he's vomiting, intubation is also indicated to protect his airway. And we look at that Glasgow coma scale, and again, I warn you, caution you, remind you that it is eye-opening, verbal, and motor. It does not have anything to do with pupillary assessment. That's expected to be done separately. We notice that because he only opens his eyes to pain, that granted him 2 points. His incomprehensible speech gave him an additional 2 points, and then because he doesn't really obey commands, he's not purposeful movement, he only withdraws to pain, then that gives him 4 points for a total of 8. If the Glasgow coma scale is 8, it's time to intubate. Cute, huh? Well, let's talk about other clinical manifestations. Let's talk about what does the vomiting indicate, and the decreasing LOC, and the changes in the respiratory pattern. Well, all of those combined indicate that this guy has increased intracranial pressure. And you notice I have all the signs of increased intracranial pressure, but there's a group in the middle that's in kind of a reddish color, the widened pulse pressure, and bradycardia, and changes in the respiratory rate and pattern. Those three are known as Cushing's triad. And again, just to remind you, a widened pulse pressure means that, let's say if his blood pressure was 120/80 to begin with, then the top number, the systolic, would increase and it would be 150/80. So you've got this bigger difference if you subtracted the systolic from the diastolic. Again, I know we've talked about this before, and I'm just reminding because it's appropriate for this section. What nursing measures are used to prevent and manage increased ICP? There's the laundry list there. It's the 8s of preventing and managing ICP. I just want to make sure that you note that this is mannitol is used to medicate on the medicate part. The mannitol is an osmotic diuretic. It causes, it's a hypertonic solution, therefore fluid will shift from the cell, specifically the brain cell, and water will move into the vascular space and then it gets peed out. So mannitol is very important in trying to manage an increased ICP. Notice that the CO2 has to be diminished or at least managed on the lower end of the value because CO2 is a vasodilator. Again, this is your brain protecting itself. When the CO2 goes up, then vasodilation occurs, and that could cause an elevation in ICP. But we don't want the CO2 to be too low, because then that can cause vasoconstriction, and we are worried about brain cell perfusion. What is the consequence of increased intracranial pressure? Again, you can read all this, but as the ICP increases, cerebral perfusion falls, and that means less blood flow to the brain, which can result in ischemia, brain infarction, and of course, it will last for continued edema, and so we'll just increase. Because of his worsening symptoms, I didn't put this, but let's just add the patient was intubated, and because of the decreased level of consciousness, the patient is urgently sent to the X-ray department. Again, if you have a patient that is respiratory compromised, analyzed, and the physician is, oh, we got to get him to CT, we got to get him to CT. The last thing you want to do is put that head in a CT scanner and then have the patient have an apneic episode or respiratory arrest. You've really got to be proactive in ensuring that this patient's A, airway is protected from the vomiting that he's been doing with an ET tube, and B, that he is mechanically ventilated so that his CO2 doesn't go up, up, up. After the CT, the results come back and a linear skull fracture and epidural hemorrhage are identified. And I just threw this in because we really wanted to talk about some traumatic brain injuries, what kind of bleeding they cause. They can cause subdural, which is venous, and in this instance, our man have arterial bleeding. So this is an epidural. Epidural is arterial, and what can happen is as the skull fractures, then that can tear the blood vessel and cause bleeding to occur. And the classic symptoms are just like what I listed. They have a brief loss of consciousness at the scene, followed by alertness, that is then followed by a decreasing level of consciousness over 24 to 48 hours, which is why on every test answer choice, what is the most indicator, the best indicator for problems in the head, and of course you always list levels of consciousness that are changing. Epidural hemorrhage, because it is an arterial bleed, is considered a neurologic emergency. The patient is taken to the operating world, and a surgical evacuation of the clot, and then of course prevention of further bleeding is going to be also done. And because there's always a concern with trauma with any head thing that is this severe, the concern of increasing ICP, because after we do surgery doesn't mean that the swelling stops, it will continue. And so the neurosurgeon also inserts that ventriculostomy, that's a bolt inside his head, to monitor and manage the ICP and CPP. The patient returns from the operating room with mechanical ventilation, and the nurse is managing the ICP by draining the CSF. More mannitol is given. His blood pressure, heart rate, and ABGs are within accepted parameters. We're doing neurochecks, and they're unchanged. He has a Glasgow Coma Scale of 6. Why would the physician order Dilantin, and why does it have to be given in an down an orogastric tube? And let's look at that. Well, first off, Dilantin, any kind of head injury, any kind of head problem, brain problem, puts the patient at risk for seizures, so Dilantin is an anti-seizure medication. Here's the big thing that you've got to always remember. You have potential for decreased cerebral perfusion, and so you want to keep those cells chilled, sometimes literally chilled. We put them on a cooling blanket because we want their temperature to go down, because that decreases the metabolic rate. And anything that causes an increase in the metabolic rate, which means the brain cell now needs more O2, is a risky thing. So we don't want this individual to have a seizure because of the risk of increasing the metabolic rate. Well, I mean, none of us want a seizure, but we're going to be specific why we don't want to have this patient have a seizure. Why was an OG tube, an orogastric tube, inserted instead of an NG tube? Again, anytime there is a linear skull fracture, we know that now linear skull fractures are usually down around here. I know my picture kind of looked like it was here, but I'm just making this scenario up to give you all the bad things. And if there's a linear skull fracture, if that bottom plate is fractured and you put an NG tube through the nose, you can see this wonderful interventionalist here put the NG tube in the brain. You don't want that to happen. So anytime there is a skull fracture that's suspected, really any facial trauma, anything going on with the head and face, most of the time orogastric tubes are inserted, and it's the same process. It's just going to be shorter because you don't have to deal with that nose part, and quite frankly I think it would be more comfortable to have it down your throat instead of in your nostril. The nurse is going to maintain strict aseptic technique while draining the CSF. I've given you a heart rate, blood pressure, and an ICP. Here's the mechanical ventilation settings, assist control, tidal volume is 600, and so on. We've got the FiO2 set at 40%, and the O2 saturation in the artery is 100%. It's at the best it can be. So the things I think you should do are calculate the CPP, and would the perfusion to the brain, the O2 delivery to the brain, be improved by increasing the FiO2 to 50%? And why is it important to use strict aseptic technique? And again, if we calculated the CPP, we come up with 57.33. That is less than 60. So there is definitely a diminished perfusion to the brain cells. So you think, oh, perfusion, that means O2. Let me go ahead and deliver more O2. Well, it's not really an O2 issue. There's plenty of oxygen in the blood. Saturation was 100%. The problem is that the blood cannot get to the brain because the intracranial pressure is too high. So that the action that the nurse should take is ensuring that she has all the eights going for her, that the CO2 is at a good level, that the head of the bed is elevated, that she's spacing out her interventions, and that she's draining off CSF. So these are the things you would want to ensure when your CPP goes down. And then, of course, if your immediate nursing interventions don't improve, then you're going to have to call the physician because there may be a necessary for some more aggressive action. What about the use of aseptic or a strict aseptic technique? Well, I think this is a no-brainer. The patient has a scalp laceration, a skull fracture. He's at risk for infection. And as we said, the last thing we want is to increase his metabolic rate. So if he developed a fever because of an infection, then we can potentially really tip his brain cells over the edge because there is just not going to be enough oxygen delivered to those brain cells. In addition, when you have a fever and you have an increased metabolism, well, that means your cells are busy working, which means they're busy making waste products. And the metabolic waste, which are produced by the cell, cause vasodilation. This is again part of autoregulation. As soon as there's a bunch of waste, well, the brain says, well, I want to get this stuff out, so it vasodilates so that blood flow will keep a-going and head on out of the head. So again, anything that increases the metabolic rate, such as infection, fever, anxiety, pain, any of those things, you just want to try and avoid for your patient because you don't want to worsen brain tissue ischemia. I hope this has been helpful. If you have any questions, be sure and email me.